Thank you so much for folks attending and folks who are maybe attending virtually. So autism spectrum disorder, hot topics in the community. I realized after I did the presentation, maybe it should be critical topics in the community or key topics. So this is the Fielding Alumni Association. I'm going to tell you a bit about myself so we can get grounded in who I am and kind of how I'm thinking and approaching autism. One of the hot topics that we'll talk about is the fact that there are, seem to be more and more unique ways to present to approach autism. So I'm a PDS faculty in the clinical psychology program, PDS meaning professional development seminar. So I'm in the Cleveland area. I teach in the cognitive behavioral track, assessment courses, developmental courses. I'm also a licensed pediatric psychologist by training and really by vocation. Like in my heart, working with kids and doing pediatric stuff is pretty important. I work also with, I work primarily with kids on the spectrum, but when you work with kids on the spectrum, you're also, particularly for assessment, you're also working with and evaluating for things like anxiety disorders, ADHD, genetic conditions, and then I have a unique focus with young children, so birth to 5. I also consult in schools and consult and do training with pediatric residents. I oversee an autism navigation program, which is, we'll talk a little bit about some of the health disparities we're seeing with autism and kind of how navigation and other things address some of those disparities. So when I talk about autism, there's a number of different approaches to autism. I really approach autism from a neurodevelopmental lens and framework. And that's going to come out. And so as we're talking about these things, would love to hear other approaches or other viewpoints. But my research and my frame and thinking about kids on the spectrum is really from a neurodevelopmental lens. One of the other things that we're going to talk about today is just some of those intersectionalities for individuals with autism. I have my own intersectionality. So not only am I a faculty member and a pediatric psychologist, but I'm a parent. And so when we're talking about particularly assessment and what we bring in as the assessors or as a psychologist, being a parent is a factor. I'm also a white, cisgendered, heterosexual, middle-aged female. And so as I'm presenting and reviewing information, those biases come into play. And then I have some fun biases, like I love running, eating cheese, and reading. Today, we're really going to do like a broad range of topics. And so really what I did was I did a really thorough kind of literature review and listened through my colleagues and the communities that I work with. I work in a large developmental clinic. I also am affiliated with some national organizations related to autism. And it was really, as I'm listening to topics that are in conversations that are happening within the colleagues and within the literature, I really developed kind of a list of topics to review or to discuss with you guys today. So we're going to talk about the differential diagnosis challenges, of which there are many. Just kind of an update on genetic and environmental factors, diversity on the spectrum. And so this is a pretty significant topic and one that's, we're going to touch on diversity, meaning females on the spectrum, health disparities as they connect to being on the spectrum, this intersectionality between sex, gender, and ASD. And then finally, the changing views of ASD and treatment. So kind of a shift towards neurodivergence as an approach and as a conceptualization. And then some of the ethical concerns related to treatment options, particularly ABA. So that's what I'm hoping to get through today. Okay, and so the slide decks, so in the recording and so one of the things, and I think most folks on the call here are pretty aware of the DSM-5 criteria. I'm not going to spend a lot of time going through. I think a couple of things, the DSM-5 Diagnostic and Statistical Manual, which is our manual that we use for diagnosing. I want to start with the premise that it is what we use in for medical evaluations, for psychological evaluations, but I'm approaching it with the mindset that it's not infallible, right? We know the DSMs are current best guess at how the symptoms cluster together and what symptoms are most consistent. But we also know that, the DSM changes over time, that there's cultural mores that come into play. And so we just want to make sure that we're recognizing the DSM for what it is. So the DSM-5, I did want to note the text revision for the DSM came out maybe March. There was a couple of changes. One change is already been consistently being implemented, and that means one of those changes was clarifying that the social criteria you must have all of the following symptoms. Before, the word all was not there, even though it was implied, and they've shored that up a bit. The other piece, though, that was not, the other piece is when you diagnose a child with autism, they also want to know if there are any associated conditions or behaviors that impact the child. And so prior to the text revision, the language was just asking for any other conditions or disorders that impact the child or adult. As you can tell, my language is always going to be pediatric centered. But in the text revision, it asks for, are there any associated conditions, disorders, or behaviors? So maybe your client often has self-injurious behavior. While there's not a diagnosis for that specifically, you can write that as a behavior of concern. Maybe they frequently elope. Those are things that we definitely want to communicate to the other providers. And now the nomenclature has shifted to allow and to really encourage those pieces. But the criteria for the DSM-5, which came out about 2013, moved from having 3 distinct disorders for autism to having one spectrum. Essentially, you're on the spectrum or you're off the spectrum. And then you have different levels of need, and those levels of need should correspond to the level of which the level of which you're on the spectrum. So level 1, level 2, or level 3. So I'm not going to talk more about that unless there are questions, but those are the criteria. The criteria, though, come right into some of the challenges that we're experiencing. And so the challenges, and this is a nice visual pictorial of the symptoms of autism, and then we have the associated conditions. So if we go back to we see that these are the core symptoms of autism. So there's social communication difficulties, and there's restricted repetitive behaviors, or activities, or interests. And so we can see those right here in the middle bubbles. So this is the core of autism, but as part of an autism diagnostic evaluation, or just as part of autism, we also know that we have all of these other associated conditions and behaviors. And so those are things like depression, anxiety, medical, so there's associated medical conditions, GI issues, sleep issues, epilepsy, motor problems. And so one of the, very difficult challenges for differential diagnosis is figuring out which is primary here and which is secondary, and recognizing that there are so many symptoms that often co-occur for individuals with autism. And so it makes it differential diagnosis very difficult. The other thing to recognize is that as part of the being on the spectrum, you have to understand that clients' adaptive functioning, language skills, and intellectual ability to truly meet the DSM criteria. So as part of the DSM criteria, we have to note if the disorders with intellectual disability, their level of language functioning, and their adaptive functioning. And so essentially you're really evaluating the entire, getting a broad view of the client in order to make differential diagnoses. And it's no small task. So when we changed from the DSM-5 to the changes to the DSM-5 from the DSM-4, it allowed for the diagnosis of autism and other diagnoses. Prior to that, you couldn't be diagnosed with both autism spectrum and ADHD. those conditions didn't co-occur. The belief or the thought process was that individuals with autism tend to be hyperactive and inattentive, but that is part of autism. It's not its own distinct condition or disorder. And so when they changed the DSM-5, it allows these other conditions to co-occur. And so now ASD is on the table for everyone, regardless of other existing conditions. The challenge, though, or one of the many challenges, is that instruments that were designed and validated based on the ASD referral sample from 20 and 30 years ago are now being applied to individuals with much more complex behavioral presentations, many of whom, or some of whom, were underrepresented in the original validation samples. So some examples of this are more significant psychiatric disorders, rare genetic syndromes. And so we know, conceptually, we know this is that we want the validation sample to represent the populations that the test is going to be used for. But that's not the case. We don't have, for many of these more complex presentations, they weren't represented. And so it's going to makes it much more difficult as a clinician to untangle and to have faith in some of the measures that we're using, knowing from a psychometric standpoint that your client was not really represented. And so we'll talk about how that even goes into, further, that females tend to be underrepresented in those original validation studies. And so how that's impacting the prevalence rates and the identification of autism in females or some of these other individuals with more complex presentations. I'm going to pause. Any questions or comments or thoughts about any of that? Well, feel free to, throw up a hand or put something in the chat if you do. This just is a list of the common co-occurring conditions. And so we know that particularly intellectual disability, that the rates of co-occurring conditions varies pretty significantly depending on what study you're looking at, what sample you're looking at. So individuals with intellectual disability, depending on the study, those rates can range from, I believe, 40% all the way up to 70%. It also depends on if you're, looking at borderline intellectual disability. Language delays are very common, learning disorders. Anxiety and depression are also very common as co-occurring conditions, as well as Tourette's syndrome. So I like this little table right here. I think one of the other trends that we're seeing related to differential diagnosis and some of the challenges is recognizing or acknowledging that the particularly, this is from outpatient clinics, that the symptomology of the kiddos that are being referred is more subtle. So this is from data from 1998-99. So we're looking at over about 20 years ago. And this is the mean autism symptom score. So for those of you guys who may not be familiar or may be familiar with the one of the common measures that we've historically, and some people are continuing to use for autism diagnosis, is the ADOS, the Autism Diagnostic Observation Scale or Schedule. And so this is the total score from that measure. And what this is telling us is that a long time ago, 20 plus years ago, most individuals that were coming in for evaluation were getting very high scores, meaning that their autism would probably appear to be more obvious, that their symptoms were pretty notable. And so the differential diagnosis process was probably a little bit easier because their symptoms were much less subtle. These are probably kids that have more high needs and were maybe more traditionally or more classic symptoms of autism in kind of the old conceptualization. Over time, and this is 2014, I think that it's almost 10 years old now. Over time, what we see is that the mean autism score is going down. And so over time, we're seeing older kids coming in for diagnosis, and we're seeing that the symptoms tend to be much more subtle. The cutoff score, depending on the age of the child, is about, I think, is between 6 and 7. So what this is telling us is that more and more kids are coming in for evaluation that don't meet the criteria than do. It also tells us that, historically the job was a little bit easier because the symptoms were much more clear. So anybody in the field right now is the common conversation I'm having with colleagues is the kids that are coming in are more complex. Their symptoms are more subtle, and it is making it more difficult to have an accurate diagnosis. Some other challenges that we see commonly with issues across diagnosis are variability among and within the disorder. So as I mentioned before, the field moved from the DSM-4, where we had 3 distinct disorders. So you could be diagnosed with Asperger's syndrome, autistic disorder, or PDD-NOS, pervasive developmental not otherwise specified. And so each of those had their own kind of prognosis and kind of their own culture in some ways. Asperger's syndrome tended to be the least stigmatizing and the most preferred diagnosis. But what we found was across the three disorders in the DSM-4, there's still an amount of variability. And so now that we have everybody on one spectrum, that you're on or off the spectrum, that variability has even increased. And so we are, as a field, moving away from terms like high functioning, terms that we have historically used, particularly around Asperger's syndromes, and focused, because functioning, while there's so much variability within, that the functioning of an individual is not a good prognostic indicator, and the functioning of an individual is often confusing for parents and for the clients themselves. So we're no longer using that term of high functioning, but we still need to recognizing that within the disorder, we have a range of individuals. And so the needs of the individuals look very different across the spectrum. And so that's a diagnostic issue, right? It's really difficult when we have we put 15 individuals who are on the spectrum in a room, and we don't see a lot of commonalities, or those commonalities are becoming more and more difficult to pick out because of this variability. So as a field, that's something we have to grapple with and have to, it makes it very difficult for that kind of concept of face validity. How can we ensure that, the people are accepting and understanding what the autism looks like, when on the face of it, the individuals with autism do present quite differently. Other issues we know is variability in presentation across setting and rater. So when we're thinking about the diagnostic process for autism, we often want and expect there be multiple ratings from multiple settings. So home and school, home and work, as well as multiple raters. So a teacher, a parent, a spouse, if you're doing an adult evaluation. And so one of the other challenges is that oftentimes we're getting, and we're finding that there's very discrepant data. So particularly for individuals on the spectrum who have less need, particularly around social, or maybe have more compensatory strengths cognitively, their presentation with trusted in home settings or settings where they're much more comfortable may appear to be much more typical. And so that makes the data appear very inconsistent. So one rater may report this, they never have eye contact and they have difficulty engaging in social conversation and back and forth turn taking, but maybe in the home setting, they're seeing very different reports. And so the challenge is making consistent data out of that. What does that mean? Does that mean they're just shy? in the other settings, or does this still connect back to autism? Other issues are COVID-19. We'll talk a little bit about that later, but we recognize, it's important to recognize COVID had a significant impact both on the social engagement of kids across, the global pandemic made it very difficult for kids to socialize in typical ways. We're also seeing some research that talks about other associated conditions with autism, like self-regulation, that's being delayed or has been delayed in a number of children, particularly preschool age children. So COVID also made it very difficult to do evaluations. So the ADOS is a semi-structured play-based assessment. So the tool that I mentioned before that's more common is probably one of the most commonly used measures. And so it's a play-based assessment, but if I'm in a mask and my client's in a mask and I can't do social smiles and make play with toys, because every toy that they play with, they have to wipe down after we're done. It made it very difficult. And so some practitioners switched to tele-assessment. And so now we're trying to do autism evaluations through through tele-assessment. And some folks did it successfully. Other folks found that, they weren't getting good samples and weren't able to accurately observe the child's behavior. So in the end, COVID-19 impacted both the behaviors we were seeing for typical and kids on the spectrum, and made it difficult to gather the data we needed to make good decisions for most of our kids on the spectrum. And then finally, we have these reporter issues. And so the reporting challenges we see are not unique to autism per se, but really when we're thinking about autism, we want to make sure we're often thinking about how we can get good data and how in ways that the reporters may function. And so what we know is that sometimes for adults or adolescents or even children, that sometimes families members may accommodate individuals with autism, so they may not see a problem. So one example is, a preschooler who just came into the office a couple of weeks ago. The parent commented on how they didn't have any concerns, but the teacher in the school had concerns. So anytime the teacher was asking the child to engage socially, the child just really struggled and didn't have those skills. But the parent didn't have the same concerns. And so I was asking the parent, what are your expectations for the child? Do you take them to the park? Do you expect them to engage with others? And the mom said, whenever she asked him to do those things, he'd have a tantrum. So she just doesn't ask him to do those things anymore. So across autism, we see kind of some unique reporter issues, meaning that sometimes the family structures or the larger community may be accommodating individuals or changing the rules so that it prevents certain behaviors, and that makes the expectations different, which creates some reporting issues. Difficult to get accurate information around that. Okay, I'm going to skip a couple of those. We may come back to those. I want to make sure we have time for. Okay, so hot topics. So the first hot topic we kind of mentioned was these diagnostic challenges, and that's really for those folks who are clinical psychologists who are doing autism evaluations. That seems to be the hottest topic, is how are we doing good evaluations? How are we untangling some of these common comorbid conditions like ADHD and anxiety? Some of the comorbid, and then what we're also seeing is that we're seeing a lot of false positives. So wherein symptoms of other things like mood disorders, eating disorders are mistaken for ASD symptoms, or we're also seeing, we also recognize that if there's a comorbid condition, it's going to increase the likelihood of an ASD diagnosis. So the age of the first ASD diagnosis is a strong predictor of comorbid conditions. And so we're starting to just look for patterns when we're thinking about the diagnostic process, and starting to try to see the bigger picture as far as some of the decisions we're making, clinicians are making kind of as a whole. And what we're seeing is that age is an important factor that we need to be considering. This slide, and I feel like it's a little out of place, but we're going to go for it. So when we're thinking about the kind of other hot topics, we're seeing suicide. So as we're seeing a significant increase in mental health needs for all individuals, the pandemic has impacted all individuals, but particularly youth, particularly 13 to 18-year-olds. We recognize that there's an increased risk for all of our 18-year-olds for anxiety and depression. But when we look more deeply into suicide risk as it connects to anxiety and depression for individuals with autism, we're seeing some pretty significant numbers. And so what we know is adults with ASD are at a higher risk for suicide, suicide attempts, and suicidal ideation. So just across the board. Individuals with ASD who died by suicide tend to be younger than those who died without ASD. So anybody who has ASD, we should automatically be thinking about putting them at a higher risk. Like that's just another risk factor. We also are seeing though that their preferred method of suicide is less likely to be a firearm. So some of the ways in which they commit suicide don't fall into our typical pattern. And then the last one here, and we're going to talk about females here in a bit as well. Females with ASD are 3 times more likely than females without ASD. That's a really significant increase. And so particularly individuals with higher cognitive functioning, we're seeing that the females with ASD who are average or above average cognitive functioning and have that comorbid anxiety and depression have these really high risk of have a strong sense of differentness, have a strong sense of not feeling supported, and are much more likely to die by suicide. Suicide for females compared to males still tends to be lower, but for individuals with ASD. So one of the things that we need to kind of shift is some of our education around what we expect when we're doing lethality and risk assessments, and do much more strongly consider ASD as a risk factor. I think at this point, probably everybody on the call is aware or knows of genetic and environmental, that our research has been pretty clear that ASD is a genetic condition. This is kind of a 2019 study, a 5-country cohort study. I just wanted to update everybody on where we kind of are with what we know. So yeah, large sample size. So of roughly 2 million children, the ASD diagnostic rate was about 1%. So when we think about things like, so we have maternal effects, and so those are genetic influences that originate in the mother, but are independent of what's inherited by the child. So that could be things like gestational diabetes. That has a fairly small or minimal contribution. So I think when we were originally, 20 years ago, we understood there'd be some genetic contribution, but we didn't understand if it was a maternal, it was shared, a non-shared. Shared environmental effects. So those could be things like, poor air quality. Those have a risk from, depending on what study you're looking at or what country you're looking at, 0 to 14.5%. Non-shared environment, so those exposure that uniquely affects the individual, and that's between 15 to 34%. But really, once we get down here to this inherited genetic contributions, 80% of ASD risk, although it did vary by country. So Finland was 41%, Israel was 87%. I think the study did a nice job in looking at heritable and non-heritable traits, both that have been known and less known, and really just kind of reiterating that it's the inherited genetic factors, and that across countries the genetic risk was similar, with some differences. And so this suggests, though, that maternal targeted interventions are probably less influential. So for a while there was some focus on, once again, like looking at maternal gestational diabetes, and that as a focus, as an potential intervention to reduce the rates of autism. But the research doesn't show that that's the primary piece or primary condition. So, just as a reminder to everybody, strong genetic component, that's been found pretty consistently across the literature. So just kind of standardized prevalence rates by race ethnicity. This is data from the UK. So this is the male to female ratio, and then this is the race ethnicity. And so I think that data connects to the next slide. And so this is a topic that we often see, or often are aware of from a kind of a public health standpoint, but that we often don't. So I'm going to talk about the navigation and some things we can do to hopefully address this. So this is with children. So research has been very clear that racially, ethnically diverse children with ASD are more likely to experience delay in access to diagnostic and early intervention services. African-American children specifically, compared to their white counterparts, are diagnosed at least 1.5 years later. African-American children are more likely to receive another diagnosis, typically a more stigmatizing diagnosis, or it's typically a ADHD or ODD diagnosis before receiving the correct. So back to that false positive rate I mentioned before. African-American and Latinx children lag behind diagnosis and treatment and receive fewer ASD treatments. So once they are diagnosed, they're not going to receive the same level of treatment or the same number of services that their white counterparts do. When we don't consider race, but we just look at socioeconomic status, many of the same kind of pieces appear. And so oftentimes we know there's some intersectionality there between race and socioeconomic status, but we're just looking at socioeconomic status. There was a delay in timely ASD diagnosis, and there are fewer hours of ASD treatment services. And for those of you who work in or work with kids with autism or don't, the research has been pretty clear. It's pretty clearly made a strong logical argument for the importance of early intervention. So when we think about there's a delay in 1.5 years of intervention or of diagnosis, that 1.5 years could mean 3 years growth depending on the age of the child. And so we want to acknowledge that is a significant problem. And so there have been a couple of different ways to address that, or to yep. So perfect question, Rosalind. So what can we do to address that? And so one of the programs that I run is an autism navigation program. And so that program was navigation services started in oncology, so medical oncology, and really started to actually address health disparities with individuals with cancer. So this idea that you're diagnosed with cancer, and then you're given 1,000 referrals and directed to do 100 different things. And what they found was that particularly individuals who had fewer resources, or individuals with who were Black or Latino, were less likely to follow up on their referrals, were less likely to get the care that they needed. And so they created these navigators. Navigators can sometimes be social workers, psychologists, even peer educators. But essentially, navigators help folks navigate medical treatment, and get them essentially to where they want to go. And so navigation can occur. So we've created, what I've created, and there've been a couple of other programs created, is Autism Navigation Services. So this idea that we're going to navigate or create supports for families, and we're going to navigate one of two ways. We're either navigating from pediatricians. So when the pediatricians call and say, hey, I've got this family and I've got this kid and they're, I think that they have autism. Can you help them navigate as quickly as possible to a diagnostic evaluation? Or a child's just received a diagnosis and they need to start intervention. Can you help them navigate from the diagnosis to interventions that they need? Both of those times we found that navigation services, both research in the oncology field as well as the autism navigation, cut down that amount of time, particularly for those most in need. So that's one way we can change some of those disparities. But the other thing is just being aware that those disparities exist. I think that up until now, we have assumed we haven't had the data, which is crazy. We haven't looked at the data. We've had the data. We haven't looked at the data and done a really good job of looking at what we're doing in our autism diagnostic clinics that are perpetuating or continuing that process of delaying that. Other questions or other ideas? Because I think this is such a key area of need and an area of concern. Okay, I'm going to go on because I could talk about navigation for days, but it's probably not why you're all here today. So the next slide is about, so we're going to start talking about the other big topic that we're hearing a lot about is in diversity on the spectrum is females. And so we recognize that, looking at the age and sex prevalence rates, females are underdiagnosed. And so if we just start out with that premise, then I think Rosalind's question about what can we do to change that? Oh, Rosalind, is there additional research that could be done to assist with ASD? Yeah, I think so. So Rosalind, I can happy to share a couple. I can share a couple of articles with you. There have been a couple of studies for navigation. There have been a couple of blind review study or studies where they're waitlist controlled studies where they've compared navigation programs and their effectiveness. I think we're at the beginning with autism navigation. They're also creating navigation programs for other chronic health conditions. So, kids with asthma, kids with where we see health disparities in outcomes. I think the idea of navigation is a great one and can go broadly. But the research on autism, I think there are probably only 4 or 5 studies out at this point. But the same questions can apply, right? So we have a population that's undiagnosed or underdiagnosed or underserviced. How can we as a field kind of close that gap? And so I think the first thing is really, as I said before, just with individuals and health disparities, recognizing that there's a gap, saying there's a gap, acknowledging there's a gap. And as we're thinking about the gap in females, I'll keep kind of applying this back to other underserved. So based on race and ethnicity, one of the challenges that we're seeing for females is the model for autism has been developed primarily on males. So back to my comment earlier, where we have tests that we're using that were standardized on a probably more male presentation of autism, more classic autistic traits. So, difficulty making eye contact, but may not fit the female presentation. There's some research to indicate the tool that we're primarily using for the autism diagnostic observation schedule. And I think where a lot of us are using that because that's what insurance is at this point mandating often, is less sensitive for females. And being less sensitive and being, because there's more likely to be a other diagnosis first for females. Back to, we mentioned how females are more likely to have an other diagnosis first. It's going to increase the likelihood that we're going to make some sort of error in judgment, that coupled with the lack of sensitivity. There was an interesting study. So they took females, and I make sure I'm getting this right. So they took females who were actually diagnosed as being on the spectrum, and they asked their teachers, therapists, and parents it was a qualitative study. They asked them about their signs of autism. So they basically were asking them open-ended questions about the signs of autism that they saw. Even though the girls were already diagnosed as being on the spectrum, teachers, their therapists, and parents still had difficulty seeing the signs of autism within these girls who were females who were diagnosed as being on the spectrum. What they saw, or what primarily came across, was the depression and anxiety. And so that information is, I think pretty notable. And it's leading to this idea that we're seeing a female autism phenotype. And so there's not consensus on this. So I'm gonna say that right here. So those of you who work in the field, or there's not an agreement that the female autism phenotype of what that is exactly, or what that looks like. I think we're still in the research phase of that. But I think what's emerging is this, that females with this phenotype to have more subtle behaviors. So where females will not have those significant externalizing behaviors. So the tantrums, the self-interest behavior, the behaviors they have are more subtle. They have fewer signs of repetitive behaviors or narrow interest. So when they do have these repetitive behaviors or narrow interests, they may appear to be more typical. So maybe it's a 5-year-old who likes unicorns. So that interest we call them a pink flag, meaning it's not a red flag. A red flag would be if their repetitive interest was, the kid only liked stop signs. And I've had a kid who really likes stop signs, and that's all they want to talk about. So we may have a 5-year-old who's a female who likes unicorns, but she really likes unicorns. Like, that's all she'll talk about. Nothing else, over and over again. So there's a repetitive piece, but the areas of interest may be more typical, or may appear more typical. Overall, there's more social motivation. So they do want to engage socially. They have those superficial social behaviors. So back to faking it till you make it. Females with this phenotype are more likely to be able to fake this behavior of typically developing. There's maybe some more subtle symptoms, but maybe it's not till middle school, maybe it's not till late elementary school, when the social understanding comes into play, that they struggle more, meaning that they are going to they're going to have more difficult when things become more nuanced. And so the superficial social behavior, the please, the thank yous, making at least inconsistent eye contact, tends to be more typically developing. The co-occurring emotional and behavioral difficulties may be partially influenced by gender. So back to what we know just about not kids on the spectrum, but the presentation of, or the depression and anxiety symptoms in males versus females, particularly in the US. We see, with males that there tends to be more of the externalizing. Our girls on the spectrum have these internalizing, so they're going to be less likely to be picked up. Their behavioral difficulties are going to be influenced by gender, so they tend to be more internalizing. And then they said that these repetitive behaviors may be influenced by gender and kind of societal norms. So once again, they are, from a normative standpoint, they're going to be more within the normative typical. So they're less likely and less comfortable to engage in behaviors that are less typical. So they're more subtle to detect. The term camouflaging probably comes up. So they have, or masking. So they can suppress or stem their behavior or suppress their stemming behaviors. Maybe they're more likely to recognize in situations where it's acceptable or not acceptable. They may not understand why, back to social understanding. So they may not understand why I can't do this, but they understand that they shouldn't be doing that behavior here. And so particularly when they're in social situations at school, they keep it together. And then when they come home, they keep it together, but it comes at a social emotional regulation cost. And so they're really struggling internally. And so that goes back to the slide we talked about where females with autism tend to have a higher suicide rate, completion rate than those with females without who aren't on the spectrum. And so I think it's really important that we're kind of aware of the phenotype or the emerging phenotype and how gender and societal gender norms are potentially coming into play in different ways. I see there's a few more folks in the room, so please feel free to put in the chat or even just come off chat, come on come on camera or just ask any questions. I would like this to be a little more of a conversation. I'm happy to continue to lecture, but I get to lecture all the time. So if you guys have any questions or comments, please feel free to join in. Okay. And then we're gonna, so back to the diversity on the spectrum, we're thinking about this intersection between, so we have another intersection of sex, gender, and ASD. And so we know that sex and gender, they're separate multi-component dimensions. The research is emerging, but inconsistent, but there's a greater likelihood of incongruence between assigned sex and gender identity among individuals with ASD. And so that research, and that kind of, it connects back to a number of different factors. I think the theory is that autism-related characteristics may facilitate greater freedom with gender roles, particularly for males on the spectrum, males who are assigned male at birth on the spectrum. And so they may feel more comfortable and more freedom. And then it also brings back to thinking about vulnerable groups. So being on the spectrum, particularly for a female, is increasingly vulnerable. For a male, makes you increasingly vulnerable. But if you're gender diverse and you're on the spectrum, then we have, the research is pretty clear that this makes a uniquely vulnerable group. I'm sure for those of you who are like psychologists or in the clinical field, probably have seen much around Texas and the Texas decision to, or it was in Texas, I shouldn't blame a whole state, the governor of Texas and his decision to no longer allow certain medical procedures or medical treatment as it relates to gender identity or changing gender identity. And so I think that as we're thinking about this ASD and hot topics, as we start to recognize the potential overlap, we, I think, have more questions than not. And so what we really need to be doing is looking at both sex and gender factors in research and clinical practice. So what this tells us is back to this idea of our tools that we're using to measure ASD don't consider or don't look at trans kids. They don't look at or diverse gender identity kiddos or adults for that matter, and how that probably is a unique group that needs to be considered in some way in both research and clinical practice. And so it's important that we're recognizing, though, the increased prevalence or the increased rate for which that is likely to occur, and how that's, the gender issues or gender diversity adds another layer of complexity and another layer of vulnerability for our individuals. Okay. I'm just looking at my notes here. Yeah, so around 15% of autistic individuals, so 2018 study, 15% of autistic individuals reported a gender identity different than their sex assigned at birth. So just to give some numbers, and that's pretty consistent with a Canadian study in 2019. About 5 to 7% of from an adult study or from a child study in the US. So when we think about those numbers, it's a notable number compared to what we see for individuals without not being on the spectrum. Okay, so this is a topic that I probably know, just neurodiversity. So much of my presentation up until now has been, we're talking about and using terms that are from the DSM. So we're orienting towards the DSM, we're orienting towards the medical model. And yet we recognize that there's, a movement within the field of autism, and within, and the movement really is being led by autistic individuals towards what we call neurodiversity. And within that, I'm going to kind of share some ways that clinical psychologists can maybe move forward and honor that and move our practice forward, but also recognize this tension between kind of living in two worlds, living within the system that is, as I said before, is somewhat broken. We have a DSM that I think many of us don't wholly believe in, making the diagnostic decisions. We have an insurance industry that is, providing primary payment and kind of preventing us from maybe doing things that we think would be useful for the client. So we have all these systems that are broken. And so how we can think about it from an individual level and from a systems level. But so neurodiversity-informed assessment is this idea that we're going to celebrate neurodivergence, that our evaluations, and so we see the individual, are going to be a strength-based approach. Neurodivergence assumes neurodivergence exists among other conditions and cultures. So it's looking at autism or being on the spectrum as a kind of common condition that occurs, as opposed to a pathological condition, or as opposed to a problem. It leads with lived experience and assumes that the client's experience is valid. What they're experiencing is, once again, part of their real world. And so we're using, the goal is not to use data to invalidate that, or not to use the assessment process to invalidate that. Focuses on affirming the identity or multiple identities of the clients. It uses identity first language. And so this is where one place where I personally struggle sometimes as a clinician. I was trained that we use person first language, so individual with autism, but the field of particularly the neurodiversity individuals, autistic individuals who are really giving voice to this, have done a fabulous job in educating and kind of pushing the field along, recognizing that autism is recognizing that autistic individuals want autism as an important, typical part of their experience, and want to lead with that. It also, the neurodiversity-informed presumes competence. So recognizing that individuals with autism, it focuses on moving away from that ableist model, where we often say we're doing strength-based assessment, and yet focus on a whole list of things that the client needs to work on or needs to change, as opposed to presuming competence. So the process of neurodiversity-informed assessment is focused on collaboration as co-searchers for truth to explain the lived experience instead of relying on tests that were normed on neurotypical individuals. And so I think this goes back to, I said, the comment about the system. So how do we engage in this given the current systems? So promoting person-centered goals using a strength-based approach and language. One of the, and this will tie into the next point I have about, conversations around ABA and some of the other treatment options. The movement away from an individualistic goals and ensuring that there's, a collaborative decision-making process around goals, focusing on what the client can do and what the client, enjoys doing. I think there's often this, idea that the current system, we want to make everybody neurotypical. And so with that approach, we're going to, take away some of the things that make the client unique. And so as opposed to, trying to reduce an area of passion, using a strength-based approach is how can we turn areas of passion and encourage that. And so we want to ensure that we're asking for language preferences with clients and families. In my area, I have families, some that want me to write reports using language of autistic individual, and some that still prefer person first language. And so I think that as the field's moving, we want to make sure that their parents are educated about kind of the difference between the two and the different approaches. And then they were given an option. Recognizing ASD as a backdrop for co-occurring conditions. And so some of you guys may have heard the term diagnostic substitution. So for a long time, right, historically, individuals with autism, the belief system was, in the 60s, that they needed to be institutionalized, that individuals with autism, it's essentially a disorder that was, untreatable, that for the client, for their best interest, that they would need to be institutionalized. We had this for autism. Before that, it was, the belief around anybody with an intellectual disability. We have a whole history of institutionalizing people who are different. And so as we've moved away from institutionalizing individuals with autism, I think we've also, so that was in the 60s and 70s, maybe 80s and 90s, we would recognize ASD, but we would not recognize other co-occurring conditions, because essentially everything could be explained by autism. So an individual who has autism couldn't also be depressed. And so we wouldn't treat any co-occurring issues like depression. We would only treat the primary autism. But when we think about that model, that doesn't make a whole lot of sense. Individuals do have co-occurring issues, and oftentimes this diagnostic substitution, we would essentially, say that all other symptoms were a result of autism. And so we need to recognize ASD as a backdrop, but recognize co-occurring issues and make sure we're treating them, particularly other mental health issues. The mental health of individuals with autism, particularly those with intellectual disability, seems to have suffered because we're not actually treating co-occurring mental. And then we need to challenge the systems and assumptions. So make sure we're asking questions about why we're doing things a certain way, or making sure we're getting buy-in from clients to make individuals with autism or autistic individuals to ensure that we're having collaborative process there. Okay, we have a couple more slides to go. This is just from the internet, the interweb, Facebook. I just thought it was a really nice reminder. So connecting to a neuro, when we're doing a more strength-based approach, just the reminder that autism is not linear. And so we're hopefully moving towards recognizing an individual's unique strengths and areas of need. And that because of that, we're not using terms like high functioning and low functioning, because functioning is not linear. we need to do more of a holistic person-centered approach. And so that requires us to look within each area or aspect of the individual, and not add a global term that for a long time has been used. We're moving more towards focusing on needs, high needs, as opposed to and high needs in a specific area, right? So they may have high needs with routines, but maybe they have, excellent skills with social. We don't want to just put one label on an individual. And I think that's what we've done for a long time as being within the autism community. Okay, so the last couple of topics within the community. So treatment approaches. And so the use of ABA, or applied behavioral analysis, has been a recent point of disagreement in the autism community. I'm just going to kind of, I guess, go through, and once again, please add comments if folks in the room here may even have more to say. But there's areas of disagreement related to concerns about historical events. So there's been some research, particularly around UCLA and Lovaas's method around both some racism and how the community has dealt, ABA as a science have dealt with that. The use of shock and punishment. So there is, a fair amount of data to suggest that, and particularly in the 60s, that shock treatment was used, particularly to extinguish behaviors that were self-injurious, and that the community, while I think is not commonly used, that it's still a procedure that is sometimes, that could be considered valid within the community. There's areas of disagreement about intervention intensity. So the research around ABA, for those of you guys who may not be familiar, there's been this idea of 25 to 40 hours a week of, on average, intervention or what's recommended. And so there, are concerns around that's a lot, that particularly depending on the age of the child. And so there have been, suggestions that level of intensity of intervention may not be necessary, or maybe too much, depending on the needs of the client. This last two, I think, connect and go together. And I think this is where I've heard most of the conversation. I think this connects very nicely back to the idea of neurodiversity evaluations or neurodiverse assessments. Or neurodivergent assessments, is stigmatizing non-harmful behaviors. So back to the idea of taking neurotypical and calling neurotypical the model. So, and a lot of times this is related to stemming behaviors. So a child rocks. And so that may bother the teacher in the classroom because they're rocking, but it's not bothering the child. In fact, the child may be, maybe helping the child, and maybe a calming behavior. I'm not sure what the function of that behavior is, but the conversation around treatment approaches is that, by stigmatizing that, by telling the child they can't do that or they shouldn't do that, we're essentially taking more of an ableist approach. So we're saying that because it bothers a neurotypical individual, and because then we need to stop that behavior. And so if it's a non-harmful behavior, then the movement or the shift is to not, or the movement is away from stigmatizing non-harmful behaviors. And so there's some concern that the field of ABA tends to do that. And then finally, the creating of goals with the intent of changing the essence of a person. So, when a child is really passionate about, or an adult's really passionate about something, creating goals that change that passion or that essence, and how much is that client able to collaborate, or how much are they involved in that process? How much are the parents educated or about the decision making, and making sure that, once again, that the client themselves is is on board with that there's a collaborative process there, as opposed to, once again, neurotypical therapists deciding that we need to change key aspects of a person. So the field is moving, which is important, but it can be confusing to parents and clients. And so I think there's a lot of upheaval, particularly around the treatment and what treatments, where to go with treatment and treatment direction. Okay, last slide here, and then we'll have some time for discussion or comments. So when you think about hot topics, this is my, I don't know if this is actually a hot topic. This is just a slide that I think is really important. So there's and it's about selection bias. And so for those of you who maybe weren't on at the beginning, I'm a clinical psychology faculty member, and I teach psychometrics, and I teach a lot about test development. And so selection bias and how we're developing tests, how we're developing research is such an important topic. So I mentioned before that we know that ASD and ID are co-occurring, depending on which study you look at, 50%, 55% from this 2018 study. But I think the key here is that ASD research tends to underrepresent individuals with ID, despite reporting results that say they're generalizable to the entire ASD population. So up until now, we've talked a lot about, or I've talked a lot about the challenges as they relate to the diagnostic assessment and how individuals, more complex cases, are not represented in the validation samples of the tests we're using. This is talking about the treatment end of things. So they looked at 301 studies. Of the 301 studies, only about half provided data on ID status. So these are treatment studies. So half provided data on the intellectual disability status. 25% specifically excluded individuals with ASD and co-occurring ID. 94% of the study participants did not have ID, and only 6% did. So of 300 studies, only 6% of the population in those treatment studies included individuals with ID. But yet 91% of the citations suggested that the studies could be applicable to all individuals. So when we think about the idea that, ASD is a broad, there's a lot of variability within ASD, but particularly when we think about the variability often co-occurs or is connected to intellectual cognitive ability. And then when we think about when we're trying to find really good treatments for our clients, or for looking at looking at the research, if an individual has ID and autism, it's most likely that the research that you're looking at wasn't done with them in mind. We know that it's very difficult to gather research with individuals with ID. Once again, that that as a complicating factor, but yet half of the individuals with ASD have co-occurring ID. And so putting it out there, I think it's really important that we're being really thoughtful about how who's being represented, both in our samples for our tests we're using, as well as, excuse me, as well as samples for the treatment populations that we're considering. Okay, so I have a few references here, and then we have like maybe 10 minutes. Should folks have questions or comments or anything that top of mind that they wanted to bring forth?
Jessica, I have a question. So I'm curious as to what can, and yes, this is really a fantastic and eye-opening presentation that you've done. So my, I wonder what other psychologists, whether they are pediatric psychologists or not, what can they do to help the parents that they work with to be advocates for their children? And really, I guess this isn't just for psychologists. I guess for psychologists, what can they do to be an advocate really for all of the clientele that they see, but what also can be done to help parents to understand, they don't see this side, possibly to have this research and have these studies to be able to really make sure that their children are being treated and assessed to the best of their ability of what's out there. Is there anything, or does this really lie on psychologists to make sure that, that we're doing all that we can to stay abreast on moving into the future and not staying stagnant and just allowing whatever has worked to just continue working, because it's not quite working, right?
No. That's a great question. So I think it takes a village. So yeah, there's psychologists can do so much, but we need to empower parents, right? Some of the research, and this is more from like the public health strand, have found, so technology is really helpful. So just by simply enrolling parents, and they're doing this more, some of this with the WIC programs and some of the support programs through WIC, enrolling them in a program where they will get weekly text about what your child can do. So they're discharged from the hospital, week 1, oh, your child should be doing this. Week 2, they get another text, oh, your child should be doing this. We're finding the research from, and this is coming, there's a partner study with that, with the CDC developmental guidelines, by just doing them and giving them in small chunks. After every well-checked visit, you get these like 4-page sheets about what your child, here's your next milestones for your child. And you put those sheets away and you never see them again. At least I do, because I can never find them. We need to be educating parents, but we need to be doing it in a way that is digestible for parents and that's easily accessible. And so technology seems to be really effective at that. And so parents these are low-income single mothers who were getting those texts were more knowledgeable about what to expect, and were more comfortable asking the pediatrician when the child wasn't following the typical trajectory. So that's one, I think, way, and they were piloting that also with, Spanish-speaking families and with a couple of other intersectionalities, so other families. So I think we as a community need to make sure we're supporting, empowering, and then I also think we need to look through other countries who are doing it better. And quite honestly, there's a lot of other countries that are doing it better. So a couple of those countries are like the Nordic countries. And so what we're finding is that they have longer term relationships with primary care. So in the US, our primary care folks, it's harder to develop those relationships. And so we need to think about how we can encourage, whether it's through use of nurse practitioners, that there's always somebody, like a warm line. Okay, you have any concerns, just call this number. It's not the same as like making an appointment and coming. But when parents just had a warm line and a nurse was answering or a nurse practitioner was answering, they were more likely to reach out for help. I don't know if that answers your question, but technology seems to be a really important key. And I'm too old for technology, so it's somebody else's game.
Yes, it does. Thank you so much. And as you were speaking, I was wondering, well, where is some of this working? And so you went right on into mentioning about other countries, that we can look at. So, and I completely agree with it does take a village. So thank you. Thank you for
Welcome. Any other questions? If not, I know you guys are on to probably other speakers. So you have at the end, so I can get there. You're welcome to email questions, or if there was like a reference that you wanted, I'm happy to provide that. And this will be available on demand afterwards. So once again, you're welcome to take a look at that at a later point. So thank you so much for coming. And I'm going to end the call right now. So have a good day.